Brenda Curtwright and Associates YouTube channel. Happy Better Speech and Hearing Month. My name is Marisol Thornberry. I've been Dr. Curtwright's intern for the spring semester. I am studying speech-language pathology at the University of South Florida in their master's program, and today I will be talking to you about mild cognitive impairment. So what is mild cognitive impairment? Mild cognitive impairment is a cognitive decline that is greater than expected for an individual's age or education, but does not interfere with daily life or activities of daily living. It's diagnosed by demonstrating a cognitive decline either by self-report or on cognitive tests in the areas of attention, executive functioning, learning and memory, language, motor skills, perceptual motor skills, or social cognition skills. Cognition and cognitive decline can be impacted by several different things in an individual's life, such as education, vascular risk factors like high blood pressure, psychiatric status such as depression, genetic background, hormonal changes, and the use of certain medications. Mild cognitive impairment is a risk state for dementia, but it is not dementia and it does not always lead to dementia. The cause of MCI is not quite yet understood, but it may be caused or exacerbated by different types of injuries or disorders, which we will discuss further. Overall, the treatment goal for MCI is to maintain cognitive status. Some patients improve, some patients decline, but our goal is to maintain status. I want to briefly discuss MCI versus aphasia. So here again, we have the definition of MCI. Aphasia is an acquired language disorder that affects language expression, spoken language comprehension, written expression, and reading comprehension. It is typically caused by any sort of head injury or stroke. It's typically associated with strokes. I'm discussing the two because they are similar, but there are some key differences. Aphasia tends to be more language-based than mild cognitive impairment, with relatively intact non-linguistic cognitive skills, such as memory and executive functioning, although cognitive deficits can occur with aphasia. So you can have MCI and you can have aphasia. You can have them individually or you can have them combined as well. MCI tends to be more globally based on cognition than it is on language, although there can be difficulties with word finding and verbal expression as well as comprehension. So when discussing brain changes, it's important to understand the different functions of the different parts of the brain. So the frontal lobe, which is the lobe right here, is responsible for problem solving, personality, reasoning, planning, emotional regulation, and motor functions. The frontal lobe is closely tied to executive functioning skills, which you may have heard me mention, which are your skills for planning and organizing. The temporal lobe, which is the lobe right here on both sides of the brain, is responsible for understanding language, sound, listening, speech, and memory. Certain areas are also tied to visual processing in this part of the brain. And it is also tied to naming, which will be important later on. The parietal lobe, which is at the top of your head, is responsible for sensation and sensory feelings such as touch, pressure, and pain. The occipital lobe, which is in the back of the head, that is the part of the brain that is associated with visual processing, visual information, and visuospatial skills. When these parts of the brain are impacted by any sort of brain change, like an injury or disorder, it can cause deficits in these specific areas. I also wanted to mention the hippocampus, which is on the inner part of the brain. It's technically located in the temporal lobe. It's an important memory center for the brain, and it's specifically linked to episodic memory, which is the memory for events or things that have happened. This is a very important area when it comes to memory, and we will continue discussing it. Here I want to discuss the top types of infarcts or parts of the brain affected by MCI. Again, we don't know what the cause of MCI is, but some parts of the brain are commonly impacted by MCI, but again, not always. Atrophy, which is a word that basically means destruction or deterioration of the medial temporal lobe, so again, temporal lobe's right here, including memory-related structures like the hippocampus, is common in MCI. The posterior-medial cortices, which are deep within the brain, and you can see them in the bottom picture, those commonly experience atrophy with MCI. That part of the brain is responsible for self-awareness, self-processing, and consciousness. Some studies suggest that there may not be one focal point associated with MCI, but widespread reduction in brain volume instead. So that would be the white and gray matter, or those cells in the brain. We'll discuss further the common types of area impacted by different disorders. So now that we know a little bit about MCI, let's discuss some disorders that are commonly associated with MCI. So first we're going to start with seizures and epilepsy. A seizure is a burst of electrical activity between brain cells, abnormal electrical activity. Epilepsy is the condition where seizures become chronic, or they happen quite often. Memory problems are a core characteristic of epilepsy. Patients with epilepsy often rank memory problems as one of the most commonly experienced problems. It's especially common in temporal lobe epilepsy. So again, temporal lobe is right here. Patients with epilepsy may experience difficulties with episodic memory, so again, that recall of specific events, or difficulty in coding, which is that process of storing information, or retrieving learned information. There is difference between individuals, however, and that is very important. Epileptic seizures in general can trigger neurodegenerative changes. So neurodegenerative means becoming worse in the brain, which eventually leads to memory impairments. Tonic-clonic seizures, which are a specific type of seizure, have the strongest predictor for cognitive decline. There is some correlation between epilepsy duration, so how long someone has had it, and the loss of neurons. So the longer somebody has had epilepsy, the more likely that they are going to lose more of those neurons. Seizure type and severity, duration, age of onset, the cause, and medications can all affect cognition. In children with epilepsy, there are typically abnormalities in the volume of the brain. So again, the cells that make up the brain. In the cerebrum, which is the core of the brain, the cerebellum, and the hippocampus, which is that memory center. A child's neurodevelopment may be impacted by seizures and epilepsy. However, this is an area that does require further research. It should be noted that there is not one single factor that contributes to cognitive decline in patients with seizures or epilepsy, not the age of onset, cause, severity, duration, or cell loss. So this is an area that needs to be further evaluated. Temporal lobe epilepsy is the most associated with cognitive dysfunction. So next we're going to talk about traumatic brain injuries, or TBIs, which you'll hear me refer it to as. A TBI occurs from a strong blow to the head or force, such as hitting the ground hard, or when an object passes through brain tissue, like a bullet. TBIs are often rated on a scale of mild, moderate, and severe. depending on the damage that has occurred and whether or not the person has been in a coma or had loss of consciousness. The temporal lobe and frontal lobe, so temporal side and frontal lobe, are the most typically impacted with TBI. Cognitive changes can occur either as a result of rapid acceleration and deceleration forces that alter the matter of the brain, or as a result of direct damage to the brain tissue and vascular structures in the brain when a direct head injury occurs. This can also cause intracranial hemorrhage or diffuse axonal injury, where the acceleration and deceleration forces damage the white matter of the brain. And a hemorrhage is an overflow of blood, which can also damage the brain cells. Post-traumatic amnesia is common directly after the injury, but cognitive deficits may occur after that period as well. Moderate and severe traumatic brain injuries are associated with more severe and persistent cognitive deficits. 65% of patients report long-term deficits in cognitive functions. Overall, the areas that are most impacted by traumatic brain injury include awareness, reasoning, language, and visuospatial processing. In mild to moderate traumatic brain injuries, it's most likely to impact memory, attention, processing speed, and executive functioning skills. In moderate to severe TBIs, memory, attention, processing speed, executive function, communication, visuospatial processing, and awareness of the deficit may be impacted. With executive functioning deficits specifically, that can include difficulty with motivation, with impulsivity, planning, judgment, and cognitive emotional aspects of decision making. Impairments are likely to persist in patients with severe injuries, although recovery is possible even up to 5 years after the injury. So next we're going to discuss brain tumors. A brain tumor is a collection or mass of abnormal cells within the brain. The presence of a primary brain tumor, so something like a meningioma or a glioma, and or brain metastases, so when cancer spreads to the brain, directly threatens cognitive functioning. In fact, cognitive deficits are present in over 90% of patients with brain tumors before treatment, so before something like a surgery, due to brain changes that the tumor causes. However, surgeries, radiotherapy, and chemotherapy can also impact cognition, although they promote and prolong survival in patients with brain tumors. This all depends on the area of the brain affected and the size of the tumor, as well as the extent of the surgery, because surgery can also improve cognitive outcomes. Psychosocial factors like mood disorders and fatigue can also impact the severity of cognitive deficits. Radiation therapy especially can cause decreased verbal memory, spatial memory, attention, and novel problem-solving ability. The tumor characteristics like the location, size, and growth rate, as well as the patient characteristics like age, cardiovascular risk factors, and cognitive reserve, impact the severity of cognitive impairment. Cognitive effects can range from mild to severe, and the most commonly affected domains of cognition are attention, memory, and executive functioning skills. So next we're going to discuss a stroke. A stroke occurs when blood supply to the brain is altered. There's either too much blood flow or restricted blood flow. Prevalence of cognitive impairment in stroke patients ranges from 20% to 80%. Like MCI in general, risk of cognitive impairment is related to age, education, even occupation, and vascular risk factors in the patient. The exact cause of cognitive changes post-stroke is not known. Deficits can occur in attention, perception, language, memory, and executive functioning. The most affected cognitive domains early after the stroke are speed, calculation, executive functioning, and visual perception and construction. Recovery is possible after a stroke due to the plasticity and reorganization of the brain structures, but some may never fully recover. Infarcts or damage in certain areas of the brain can affect cognitive outcomes. For example, damage to the hippocampus, which is that memory center we've discussed, can negatively impact cognitive outcomes. Lesions to the white matter of the brain, which is frequently associated with a lacunar stroke, are predictors of cognitive decline. White matter damage is especially related to the speed of processing and executive functioning deficits, with secondary impairments in visual memory and visuospatial skills. Overall, this can cause diffuse effects, so widespread effects in the brain, no matter the location of the brain damage. Additionally, microbleeds, which are small bleeds in the brain, are related to cognitive impairment as well. Patients with cerebral microbleeds often have impaired executive functioning skills when compared to those who do not have microbleeds. The exact impairments associated with strokes are not known, and parts of the brain affected may contribute to specific deficits. And so this is why I also mentioned aphasia versus MCI, because aphasia is commonly associated with strokes. So again, it's a language impairment after a stroke, and both can occur. You can have MCI and aphasia, or you can just have aphasia, or you can just have MCI after a stroke. Next, we'll discuss multiple sclerosis. So multiple sclerosis is a chronic inflammatory disease of the central nervous system where the immune system attacks the protective coating on the cells, which is known as myelin, and it reduces the speed and functioning of those nerves. So you can think of that coating as insulation to a wire. If a wire does not have that insulation, it's not going to function properly. Cognitive dysfunction is very common with multiple sclerosis. It affects quality of life, work outcomes, and social engagement. While the exact prevalence of cognitive impairment is unclear, the estimated range is 20 to 70% of individuals with MS have cognitive dysfunction. Common difficulties include decreased information processing speed, attention and memory deficits, impaired abstract thinking, or impaired executive functioning skills. Most individuals do not demonstrate impairments across all areas of cognition, but again, each person is different. Long-term memory deficits are more commonly affected than deficits with encoding or storing new information. Word finding, which is your ability to come up with the words that you'd like to say, can also be impacted by MS, which is multiple sclerosis. While white matter is affected, cortical and deep gray matter of the brain can also be impacted in the inflammatory process, resulting in damage to the brain and causing cortical lesions that result in physical and cognitive impairment. A study by Curtwright et al. In 2018 found that in a specific group of adults with MS, lesions, which are just damaged areas, may occur in the frontal lobe, which was about 48%, temporal lobe, which was about 33%, parietal lobe, which was about 18%, and the occipital lobe, which was 0.6%. As we discussed previously, lesions in these different parts of the brain may cause deficits in those specific areas. This same study found that 40% of their 60-person sample had mild cognitive impairment, and definitive cognitive impairment, which was more significant, was present for 18% of patients. White matter volume is thought to be a better predictor of cognitive impairment than cortical lesions, but both contribute to cognitive dysfunction. All right, so now that we've discussed some disorders associated with MCI, we're going to discuss some treatment methods. The primary goal of treatment for mild cognitive impairment is to maintain cognitive status. Some patients improve, some patients don't, some patients decline, but our goal is to maintain cognitive status. And also maximize quality of life. Person-centered treatment is very important, and the individual's wants and needs are important to goal setting and treatment. Treatment falls under cognitive rehabilitation and cognitive stimulation. So rehabilitation would be restoring, stimulation would be more for that maintenance, but it also can help improve. Treatment is typically compensatory or restorative. So compensatory would be teaching skills or different methods that you could use within everyday life to help you with your memory. And restorative would be to help restore memory. But again, our primary goal is more towards that compensatory or that maintenance of cognitive status. Underneath compensatory, you'll notice that I have listed internal and external memory aids. So internal memory aids are strategies that assist with memory or encoding, which is another word for storage of information. These are strategies that an individual uses themselves to make change. So this can include first letter mnemonics, visual imagery, association, and chunking. External aids are things that are more in the environment, such as setting reminders on your phone, putting up a calendar, using a planner, having a checklist, using an Alexa. All of those things can be beneficial for memory. Computer-based training is a hot topic in MCI. These are programs that are designed to specifically help with cognitive stimulation, and they target different domains of memory and executive functioning skills. They work on attention, working memory, and processing speed. An article by Gates et al. In 2019 found that computer-based cognitive training, when compared to a control group, can improve or maintain global functioning of cognition, episodic memory, which is that memory for specific events, and working memory in adults with MCI. However, the qualities of the studies in this review were low, so results should be interpreted with caution. But the overall outcome was that computer-based training can be effective for individuals with MCI. Further research is absolutely warranted in this area. Next, you'll see spaced retrieval training. So that is a specific technique for learning new information where an individual is guided to encode or store specific information in spaced practice over longer periods of time. So you might start with 1 minute, then 2 minutes, 10 minutes, etc. This also incorporates errorless learning, where a speech therapist eliminates errors as much as possible by providing consistent cues and prompts. This can again help with learning of information and encoding it. Finally, metacognitive skills training is also listed on this slide, and that's a treatment method most often associated with traumatic brain injury. Its focus is using goal-setting strategies to facilitate learning, such as self-talk, self-reflection, imagery, and providing feedback and tracking progress towards a goal. It's also, metacognitive means thinking about thinking, so teaching yourself to think about thinking. Overall, a study by Wee et al. In 2019 found that individuals with MCI benefit from intervention in global cognitive functionings when compared to a control group. So treatment can be beneficial. Next, I want to discuss word finding treatment. So many individuals with MCI report difficulties with finding the right words to say. So these two treatment methods that we're going to discuss are most typically associated with treatment for somebody who has anomia, which is a word for difficulty coming up with a name for something. And it's most associated with stroke, but these strategies can be used for individuals who have not had a stroke. Often people will say that they know what they want to say, but they just can't find the word, and that's where these two treatment methods come in. So the first is semantic feature analysis, which is abbreviated as SFA. It's a noun-based treatment method. It's pictured here on the slide, where you identify the important features of a set of words, or one word at a time, and you describe a target picture using these specific features by describing it. This method is thought to be effective in activating the semantic networks of the brain. So those are the parts of the brain associated with word meaning. And it's believed that by activating these parts of the brain, it's also easier for you to retrieve words that are similar to the word that you're describing. The second method we're going to discuss is VNEST, which is Verb Network Strengthening Treatment. This is more based on verbs rather than nouns. Semantic feature analysis is based on nouns. VNEST is based on verbs. And it also activates the semantic networks of the brain and can improve the production of basic syntactic structures, so basic sentence structures. You will be given a target verb, and you'll have to come up with people who are associated with the target verb and then the things that they do associated with the target verb. So finally, I'd like to discuss how social emotional components can also contribute to mild cognitive impairment. So 35 to 85% of patients with MCI experience emotional symptoms, most commonly depression and anxiety. The hippocampus, which is a memory center that we've discussed, is commonly impacted by MCI, and it also plays an important role in emotional reactivity and emotional control. Just as an example, in patients who have had a stroke, early depressive symptoms are associated with an increased risk for cognitive impairment. In patients with MS who just have depression, don't have any cognitive decline known to a doctor, depression can be linked to cognitive impairment, just depression. And that can cause impairments in learning, memory, and processing speed and executive functioning skills. Additionally, a 2011 study by Kay et al. Found that individuals with MCI leave their house less often than those without MCI, which reduces their interaction with the outside world, and it reduces their social engagement. This likely impacts quality of life and again contributes to social emotional factors. Overall, social emotional components can actually contribute to cognitive dysfunction. So it's important that an individual with MCI seeks treatment for any anxiety or depression or other cognitive or social problems that they are experiencing. Emotional health and mental health are just as important as cognitive health, and I really mean that. So they should be really treated just as importantly. Thank you for your time. Happy Better Speech and Hearing Month. Thank you.